Great. So everyone can hear okay? Very good. Well, thank you very much for the opportunity to come and speak with everyone. And Dr. Bird, I greatly appreciate this invitation. I love coming out to Seattle, and we had a beautiful evening last night. I know the sun will be out later today, too. So thank you again. You are really, the patients and the caregivers here are the real heroes of the story of melanoma, and it's our honor to be able to take care of everyone. So the topic that we'll be discussing today is immune therapy for the treatment of melanoma, and really this concept of, can we, with our own bodies, can we treat ourselves, or obviously hopefully cure ourselves? So here are my conflicts of interest, which are disclosures from working with a number of different companies in drug development and clinical trials. In 2013, the very prestigious medical journal Science chose cancer immunotherapy as the #1 advance in all of scientific literature in that particular year. And Science covers everything from astronomy, it covers everything from earthworm biology. So everything from the small to the huge, they decided to pick cancer immunotherapy as the #1 scientific advance in 2013. And through this talk, we'll try to understand a little bit as to why that's the case. While we were having these great celebrations in 2013 for cancer immune therapy, the story really began in 1891. And actually, that was the story where something else began. Does anyone know who this is? Naismith, right. Very good. Good. We have a big basketball fan here. So that's fantastic. So this is James Naismith. And in 1891, he took his famous peach basket here under his left arm and began throwing basketballs into this peach basket and invented the game basketball. And that was 1891. So so maybe people are thinking, well, what does this have to do with immune therapy? And you're right, actually. Nothing. Except in 1891, the same time James Smith was throwing baskets into the peach basket, this gentleman here was working on immune therapy. Does anyone know now who he is? Extra points for this one. A couple names? Okay, this is Dr. William Coley, who was a surgeon. He did sarcoma surgeries at Sloan Kettering Cancer Center. It was called something different back in the day. And this is a picture of him right here at, if you can see this, it's a little hard to see, Xmas party, actually 1892. This is the Christmas party at Memorial Sloan Kettering Cancer Center in 1892. We have better times these days than it looks like they were having then. But lo and behold, in the same year that James Naismith was inventing basketball, this Dr. William Coley was doing surgery for patients with sarcomas and other types of tumors and found that the patients that had post-operative infections actually had spontaneous regression of their tumor. And so this was a gentleman that he took care of with a sarcoma involving his left neck. And it's a little hard to see in this line drawing, but it was a substantial tumor improvement along the left side of this gentleman's neck, who had developed an infection after the surgery for a different type of tumor. And it was really here when cancer immune therapy was founded, with the idea that these patients with infections after surgery had turn on of their immune system, and that immune system that was turned on in that way led to spontaneous tumor regressions. So for years, he was proposing that this was a new way to treat cancer patients, and unfortunately, there was such controversy at the time about how well this would work, and it didn't obviously work in every patient, and it did have toxicities by inducing infections in these patients. So it was a long time before this really became mainstream, and it's been a lot of work for many years to get to the point where we are today in 2013 when Science selected it as the main scientific advance of 2013. So for our talk, we'll focus on a couple of main questions. Number one, how can the immune system be used to treat melanoma? Number two, what have we learned from our clinical experience treating patients in clinical trials and in clinical practice? And then number three, how do we do better? Unfortunately, immune therapy doesn't help everyone. We need to keep working until it does. So as we saw before, this is a picture of a cancer cell being killed by a T cell. And I was excited to show the slide until I saw the much better video where it was a live animation. So Dr. Lee, thank you for showing me up on this. But anyway, nice little picture. I'll have to find the video for my next talk. But it's unfortunately very complicated how the T cell gets to where it needs to go to kill the cancer cell. It's not so straightforward. We saw that final step where the T cell kills the cancer cell, but it's a very complex system. And this is a cartoon showing some of the main steps, and I don't want to go into all the details of this, but a couple of important principles just to keep in mind. Here on the left, this is a gray blob of cells called a tumor, and the tumor releases antigen. And antigens are little pieces of protein that are recognizable to the immune system, and they can be released by the tumor in a number of different strategies, or shown by the tumor cells in different strategies. And these antigens are gobbled up by these cells in the tumor microenvironment called antigen processing and presenting cells, like dendritic cells. And these cells take up the antigen, process the antigen, travel to lymph nodes. And when we have swollen glands, when we're having an infection, that's because the lymph nodes are inflamed by all this antigen presentation by these dendritic cells. And these dendritic cells are taking these peptides, these antigenic peptides, and showing them to T cells and saying, T cell, look at this antigen. This shouldn't be here. This needs to get destroyed. And the T cells see this antigen, and they see this abnormal protein, and they travel out of the lymph nodes or lymphoid tissue, go into the tumor microenvironment, and ideally result in the destruction of that cell that we saw in the video. Unfortunately, there are many, many different ways along the way that this process can be subverted, and it can't effectively destroy the tumors like we would like to. And I'll talk a little bit about a few of those strategies throughout this presentation. A few of the strategies that we've been using in immunotherapy of cancer have been trying to get over some of the ways that the normal body doesn't fight cancer. And they have been strategies like giving vaccines, or just giving more antigen to patients to see if there's more antigenic material around. Maybe the body's immune system will be awakened to the presentation of cancer. We heard in a great talk earlier, just before the break, about TIL therapy, or tumor-infiltrating lymphocyte therapy, which is a form of adoptive cell transfer where cells from the body are taken out of the body, engineered in the laboratory, or treated in the laboratory in different culture materials, and given back to patients to try to kill their cancer. And there are two other ones that we'll be talking about briefly. One is cytokine therapy that we heard about from Dr. Cranmer earlier, a cytokine called interleukin-2. And then the last category called immune checkpoint blocking antibodies. Those are drugs like Ipilimumab, which we heard mentioned earlier, and some others that target a different protein called PD-1, which I'll be further exploring in this presentation. So we heard from a prior talk today about interleukin-2, about how in a small group of patients who we don't really exactly know who they are, but they can have very, very long-term control of their melanoma with this treatment, interleukin-2. And these are curves showing in red here that the patients that have received interleukin-2 that both have metastatic melanoma as well as kidney cancer can have very long-term control of their disease for a very, very long time, many, many years, and this is up to 120 months or 10 years in this particular study. So this raises the idea that the cytokine interleukin-2, which is basically a food for T cells, can really help a group of melanoma patients in the very long run. We just don't, unfortunately, know who they are at the beginning to pick them out for this treatment. There's one famous patient that received interleukin-2 treatment. I don't know if anyone from Seattle knows who she is. She's a doctor, patient doctor. No guesses? Okay, does anyone know Dr. Izzy Stevens? Yes, a hand in the back. Who's that? Grey's Anatomy, right, good. In Seattle, I thought this would work. So in Grey's Anatomy, Dr. Izzy Stevens, great. We have one fan. It's amazing. Years ago, everyone's hands were in the room. But I thought in Seattle we may have a chance for this. Great. Very weird, right? So wonderful coincidence about this, but it's Grey's Anatomy. Here's the, what's going on. We're watching Izzy's IL-2 schedule. So it was great that it did highlight in the popular media about patients with their melanoma treatment. However, we're moving beyond some of these treatments. We're moving to other treatments that get the T cells to fight tumors a little bit more strongly. And so T cells, like every cell in the body, needs to be tightly regulated. It needs to know when to attack, and it needs to know when not to attack. If it only knew when to attack all the time, we would have autoimmune diseases, and we would be very sick from these autoimmune diseases. If it didn't attack ever, then we would also have problems with too much susceptibility to various infections and cancers. And so the T cells are tightly regulated by a number of activating receptors, here shown on the left, and inhibitory receptors, shown on the right. And it's the balance of these activating receptors and inhibitory receptors that a normal, healthy person needs to keep in perfect balance. Now, I don't want to get into the alphabet soup of all these different targets and everything that's being done now to target them, but there are drugs in clinical trials, and many of us may be considering different approaches in these ways, where different antibodies go and turn on the activating signals. Alternatively, we could keep the T cells fighting cancer a little bit more by blocking these negative signals. So you either hit the gas pedal on the T cell by turning on these activating signals, or you take the brake out of the car, and then the car goes more quickly that way too. So the T cell activity can be enhanced by blocking these negative signals. And the two most important negative signals that we'll talk about are cytotoxic T, lymphocyte antigen 4, or CTLA4, and the other one, PD-1. So the first target we'll talk about is the target of the drug Ipilimumab. And it did take me a long time to practice pronouncing that as well. It's a challenging word, or Ipi is the short version. And this is when the dendritic cell is showing this antigen to the T cell. This is where Ipilimumab works. So if any of us have received this or heard about this drug, this is how it works. Basically, the dendritic cell is bringing that antigen, that piece of that cancer cell that shouldn't be there, and showing it to the T cell through this T cell receptor here. And it requires another stimulatory signal here through these molecules shown here, B7 and CD28. And these green signals here show that the T cell is activated in that setting. And this molecule, CTLA4, comes up to the cell surface and says, too much activation, we need to calm down. And Ipilimumab blocks this interaction, or blocks this negative break, and thereby the T cells are better cancer-fighting cells, and it has improved survival for patients with advanced melanoma. It took a long time to get to the point where this drug was approved by the FDA, and we heard about some of the history of some of this earlier, but it was in March of 2011 when this actually was approved by the FDA. But the real basic biology began in 1970, when the first T-cell biology was first being studied. And so it was 20 years later, not until the 1990s, when, as we heard about later, that blocking this negative signal, CTLA4, in mouse models of cancer showed that their tumors could regress. And so that was the first time, not until the 90s. So it took 20 years from the point where we first recognized that T cells were regulated in this way until we knew that this could be a cancer treatment strategy. In the early 2000s, that's when the first patients were being accrued to the clinical trials of some of these drugs. And it was in 2004 where the big phase 3 study that we heard about earlier began accrual. And it's for patient volunteers that participate in these studies that we move this field forward, and that's absolutely critical. But it's interesting to know that this took a long time, almost 40 years or 41 years from when we first began understanding this T-cell biology until Ipilimumab was approved by the FDA. And that tells you the pace of science in some context. But what's remarkable is while it took 40 years to develop this first immune checkpoint blocking antibody, Ipilimumab, other ones have been coming so quickly that that pace is really, really rapidly moving forward in very profound and important ways. And so to give a bit of a sense, some people may think, well, 1970, that seems just like yesterday. So I don't know if you remember what telephones looked like then. I had to Google what this was because this was around before I was born. This was a cell phone from the 1990s, and this is what people were using maybe to call each other and to say, this is working in the mouse models, and this is something that might be used to treat cancer patients. And this is in the phones in early 2000s when patients were first being treated with these types of drugs, and this is the phone from 2011, and it's amazing how even quickly that has changed. So what do we know about this drug, Ipilimumab? We know that it can help keep people living with their melanoma for a longer period of time than ever before. We also know that some patients don't have typical responses to the drug. Some patients have shrinkage of their tumors right away. Some patients have shrinkage later. Some patients have stabilization of their disease. Unfortunately, it doesn't work for all patients as well. But this was an interesting patient that taught us an important lesson about the drug. This was a CAT scan that was done before he started treatment, and you could see his liver here was looked like a pretty healthy liver, maybe questionable little tiny dots in the liver, but received Ipilimumab because he had melanoma tumors elsewhere. And this was in July of 2006. About 3 months into the treatment, week 12, it looked like a lot of these areas in the liver were really substantially growing. And this was a bit concerning, making everyone wonder, is this treatment working for this patient, or do we need to switch to something else? It looked like there were more melanoma tumors in the liver. But just with continuation of treatment, actually over time, By week 20, so almost 6 months into the treatment course, these tumors started to improve in the liver. And actually, over time at week 36, it showed that they even continued to get better. And this was a really impressive lesson of a patient that had apparent worsening of their melanoma before it got better. Now, unfortunately, this isn't the case for everyone. And unfortunately, we still don't understand why is it that sometimes the tumors seem to look a little bigger before they may get smaller or before they stabilize. There are many different theories as to why this may be the case. Maybe it's just the drug takes some time to work. Maybe it's just that what looks like tumors getting worse may be the immune system coming in and those T cells destroying all those cancer cells like we had seen before. We don't completely know, but we've done some biopsies of some of these tumors at the time where it looks like it's worse, and in fact it's just a big ball of inflammatory cells and no active melanoma. And this is what's called a spider plot, showing patients treated with a different immune therapy agent called a PD-1 antibody, and we'll talk about that in a minute. But essentially showing that some patients have shrinkage of their tumor right away, and this is a patient here where you can follow with the arrow going down right away, their tumor burden shrinking. But other patients, like this one in the red here, look like the tumor burden grows for at least several months before finally around 3 months starting to turn and then improving over time. And these green X's mark patients that develop new lesions. Some of these patients, even if new melanoma areas have shown up, some of them may still have benefits in shrinkage of other areas. So we're seeing really mixed patterns of responses, and it's not so clear that everything gets better or everything doesn't get better. It's a bit more of a heterogeneous picture, and trying to work with our doctors and trying to work with the team to try to understand how the treatment may be working is one of the main challenges as we treat patients with these drugs. So when we think about Ipilimumab, that was the first immune checkpoint blocking antibody that really demonstrated benefits in patients with advanced melanoma, but we've made even greater strides with newer treatments, such as those that target another checkpoint called PD-1, programmed death 1. Have people heard of this? Yes, okay. So where Ipilimumab works is very early in the immune response, right when the antigen-presenting cell, like the dendritic cell, is showing that peptide to the T cell. So this is on the left slide. But what happens is the T cells go through the lymphatics and the bloodstream, and they go right to the tumor. In the tumor, there is an immune suppressive element called PD-L1, which, among many other reasons, is one of the reasons that the T cell cannot destroy the tumor. And so there's another strategy called PD-1 blockade or PD-L1 blockade, where antibodies are attacking either the PD-1 molecule or the PD-L1 molecule and trying to disrupt this negative element in the tumor microenvironment. So when the T cells come into the tumor, sometimes the tumor says, T cell, you're not going to kill me. I have PD-L1. It's my shield. And the T cell can't destroy the tumor. And so what we do is we try to take away that shield. We try to take away PD-1 or PD-L1, and we have antibodies that block this interaction. There have been a number that target PD-1, and I've listed a few here, and we have a number that target PD-L1. And we really don't know what strategy is best just quite yet. However, in melanoma, PD-1 has been a little farther advanced in terms of blocking PD-1 and what results we can see. So this is just a close-up of that interaction when the T cells are trying to kill the tumor directly. We first learned that PD-1 blockade was incredibly effective in patients even who had had prior Ipilimumab and then needed some additional treatment later on, in that this is what's called a waterfall plot, and each bar on this is a particular patient, and patients that have a decrease on this bar, or any of the apparent looking waterfalls here, these are patients that had shrinkage of their tumor, and these are patients, unfortunately, that had growth of their tumor with the treatment. But in these patients that had had prior Ipilimumab, in this particular clinical trial, more than 50% of the patients in this study had subsequent shrinkage with PD-1 blockade after prior Ipilimumab. And it, again, was to the gratitude of all of our patients for participating in these trials to really understand that you can give drugs like PD-1 blockade, and this was a study with the PD-1 blockade drug Pembrolizumab. You can give this to people that have had prior Ipilimumab, and it can still work very, very well. Here's a CAT scan of a patient that was a 72-year-old man who had symptomatic progression after prior chemotherapy, interleukin-2, and Ipilimumab. And this patient had some fluid around the left lung and a tumor around the heart, as well as in the liver. And this was in April of 2012. But actually, a year later, with this drug Pembrolizumab, dramatic improvement in the fluid around the left lung, dramatic improvement around the tumor around the heart, and in the liver as well. So this drug can be very, very powerful in these particular patients. Pembrolizumab, or Keytruda by the brand name, has even been shown to improve outcomes beyond Ipilimumab. And this is just to show that this new strategy of PD-1 blockade, so closely on the heels of Ipilimumab, has even improved outcomes even further than we have with Ipilimumab. And even more than we've been able to realize from just advances in melanoma, trials that involve patients receiving PD-1 blocking antibodies have been shown to help patients with many different types of tumors in addition to melanoma. These strategies are not specific to taking care of melanoma just by itself. They can work to enhance the body's immune system and can be now showing benefits in many different tumor types. So here's just a slide, a table with different PD-1 agents across many different tumor types and showing how many different tumor types have now shown benefit to this approach of PD-1 blockade. I've highlighted a couple of the ones in the boxes where the FDA has approved the use of a PD-1 antibody to treat that particular cancer. So it includes melanoma. We have 2 drugs that block PD-1 approved in melanoma, Nivolumab and Pembrolizumab. But also non-small cell lung cancer has been shown to benefit, and patients can receive Nivolumab or Pembrolizumab for that. And kidney cancer or renal cell carcinoma, that's also been shown to benefit. And these drugs have improved the outcomes of these patients with many different types of cancers. And I think we have to be proud of ourselves in the melanoma community, because this is where some of these drugs were first tested and first demonstrated benefit. And now it's expanding to patients for many other different types of problems. Head and neck cancers, hematologic cancers like Hodgkin lymphoma have also been shown to benefit from PD-1 blockade. And we're really just at the tip of the iceberg in terms of how many different types of tumors may be responsive to this particular approach. PD-L1, which is that ligand that the tumor cells express, that's also been blocked by a number of different drugs. And these are some of them here. And again, the details are not important, but just to keep in mind that there are so many different types of tumors that are now responding to all of these types of treatments. And it's expected as time goes forward that the FDA will continue to approve these drugs for patients with other types of tumors, because now there is a lot of interest in trying to treat different types of cancer with this approach. This is not just a melanoma treatment. So this is a woman, she was 96 years old, and she had a cancer called squamous cell head and neck cancer on her jawbone area. And she had had a prior treatment called Cytotoxic, and she had a HPV negative type of head and neck cancer. And HPV is a virus that can be associated with different types of tumors, particularly head and neck cancer. And she had treatment with a PD-L1 blocking antibody. And by day 28, so just 1 month into the treatment, you could see that her tumor was starting to improve. And she's smiling, you can see. She's really happy. So this can work in patients with different types of cancer. This can even work in patients that are 96 years old. And so one of the common questions that we always get is there any age dependency to some of these drugs? And while we don't have formal statistical analyses completely done on all of this yet, I think that the tolerability of a lot of these drugs are pretty good, and patients should be considered for this treatment regardless of their age. So unfortunately, with treatments that are this powerful, shrinking tumors, and we saw the head and neck cancer getting better, we saw the patient with the tumor around the heart, there are some side effects that can be associated with this, and that would be expected when you turn on the T cells in this way. It's not just for their ability to fight the tumors. They can accidentally cause temporary autoimmune-like diseases, and they can be treated with steroids or other immunosuppression. And so this is a summary of some of the most common side effects that can be experienced, including rash, diarrhea, inflammation of the liver, or joint pains with some of the PD-1 or PD-L1 drugs. And every patient's experience with these drugs is a little bit different. But at least with the PD-1 type drugs, I think one message is the majority of patients do fine without a serious side effect. And in fact, many studies have shown this is even much better tolerated with these types of approaches than with chemotherapy. Most side effects take some time to set in. Unlike chemotherapy, where you get the treatment and then you may feel sick or not so great right away, and there's a predictable time of when certain things are happening, some of the side effects can happen at varying times. This was a pooled study of almost 500 patients with the PD-1 drug Nivolumab, showing that the median time, or basically like the average time when the side effects set in, was at least 1 month, and in many cases approximately 2 months into treatment. So these dots indicate that the skin side effects typically happen first. Gastrointestinal side effects like diarrhea typically happened a little later, and then there are other side effects that can happen even later still. But the wide bars that we see here, this indicates that even though there are averages or medians, the time that side effects can begin for any one individual patient can be very unique. This is a picture of a woman that I took care of with Ipilimumab, and she developed a very minor rash. Sometimes these rashes are very, very small, and this is just a little pink rash on her arm that we just, and on her chest, and we treated it with topical steroids, and that was successful in her case. This is a patient that had a PD-1 rash that was a little more significant, in particularly the sun-exposed areas, but the key for most of these rashes is they can get better with steroids, either applied creams or different types of steroids that you could take by mouth. This is a patient actually that had a bit more of a severe rash, and it was interesting because this patient had had radiation into his chest in the past and then took PD-1, and it raised the possibility, because it was most in the chest here, it was on his hands as well, but it raised the possibility that maybe the prior radiation did something to excite the immune system, and such that when the PD-1 drug was given, it was what's called a radiation recall rash, and the area that had been previously irradiated and inflamed may have been the most susceptible to developing the rash. And this patient's rash got better with intravenous steroids. This is a picture of a patient that had a different type of a rash called Sweets syndrome, which is, can be associated with a fever and also some redness on her hands here. And this was a biopsy that was done of her skin, showing that there are a number of inflammatory cells in this particular skin. So this is something that can happen. It's important to be aware of this, but most patients do get better when they have these types of problems. Another really interesting skin side effect that can happen is this condition called vitiligo, which is whitening of areas of the skin. And this can be because the melanocytes, which normally make pigment in the skin, make our hair colored or make our skin tan when you get a skin tan, which you shouldn't do, at least not in the tanning beds, as we heard. The whitening of the skin can reflect the immune system being activated against the melanocytes and destroying the melanocytes. And so this has been, in some cases, some people believe maybe a favorable thing to happen, but it's not quite clear that that's the case just quite yet. But this was a patient I took care of that had some whitening of her arms and her thighs, and she had a very good outcome with the PD-1 blocking antibody. Diarrhea and colitis can be one of the most problematic side effects, in that patients experience diarrhea, and it needs to be treated early with steroids. And this was a patient's colon that had a colonoscopy to look and see what was going on inside, and there's some inflammation in the colon in this patient. Now, it's very interesting, why do some patients develop these symptoms like the diarrhea or colitis and others don't at all? And so when I was in training, there was a project that some of my more senior mentors proposed to collect the stool of patients to test for different bacteria in the stool to see if there was a relationship between the bacteria in the bowel and the development of colitis. And in fact, that is what was found, that there was a relationship of certain types of bacteria to the development of diarrhea and colitis in these particular patients. And this was not a project you want to do when you're the low man on the totem pole, which I was at the time. But we learned some interesting things from this study, and the next step is really to try to figure out how do you manipulate the bacteria in the bowel to try to reduce the risk of this side effect. Should you be taking yogurt? Should you be taking probiotics? I don't think we have a very good answer yet, but these are very interesting questions. Some other problems can involve the pituitary gland or other hormone glands. The thyroid gland can be affected, and the pituitary gland can be affected. And this was a patient's pituitary gland. The pituitary gland is a little gland that produces hormones that's located in the skull here. And what happened in this patient, they had Ipilimumab in June of 2004. And by 6 months later, in December of 2004, the gland was swollen, and this patient was having headaches and fatigue. And so it's very important, if you're under treatment with one of these types of approaches that blocks Ipilimumab or PD-1, that if you're having headaches or fatigue, that you really think about the possibility, or that doctors are thinking about the possibility, that this may not just be for everything else going on. This may be because there's a hormone problem going on, and these could be treated with hormone supplementation, with a thyroid pill or with a low dose of steroid for a long period of time to make people feel better. Pneumonitis is the last side effect that we'll talk about, and this is a patient's CAT scan from the lungs that developed some lung inflammation when taking these treatments. And this is another important side effect to be aware of, because if anyone's having cough or shortness of breath, it's important to bring this up with their doctor, because it can be treated successfully with steroids to dampen down the immune response if the immune system gets a little too activated. So what do doctors mostly do when they don't know what's going on? And I maybe shouldn't scare everyone about this, but this is what I do myself still sometimes. And I will admit that we're all still learning about how to take care of these drugs and how they all work. And you can Google, just type in Ipilimumab management, for example, and it'll bring up something, and you can click on that. And it brings up different algorithms of, depending on the symptoms, number of stools per day, for example, or abdominal pain, what should happen. So holding back on the drug, giving steroids to bring down the immune response, or other types of approaches using different immune suppressant agents like Infliximab, which is a TNF-alpha blocking antibody that's used for inflammatory bowel diseases to take care of patients when they're having diarrhea. And one might wonder, well, if we're giving treatment to take care of a side effect and suppressing the immune system, isn't that counteracting what we're trying to do? Isn't that preventing the T cells from fighting the tumors, and that's what we're trying to have happen? At least in patients that have received Ipilimumab, and there's some data for Nivolumab as well, the use of steroid to treat a side effect does not seem to hurt the efficacy of the drug. So I think the message is, if there's a need for steroids to treat a side effect, that's okay. These curves really show that the long-term outcomes in patients that have side effects and need steroids is the same if they've had Ipilimumab and side effects and steroids versus if they didn't have side effects and didn't need steroids. So don't worry about taking steroids to treat a side effect. The outcomes seem to be similar in that particular context. And this was a study of about 300 patients we did at Sloan Kettering. So we're trying to find a way to increase the number of patients who benefit. We know this can work. We wish this worked for everyone. We're not quite there yet, and that's why we're still working on this. And so there are a number of different strategies to think about how can we increase the number of patients who benefit from these approaches. And so the different thoughts about how do we build upon the success that we've had so far and improve the outcomes till we get to 100% involve a couple of main points here. And I'll go through two little stories of combination treatment that's demonstrated some early promise. One theory is maybe we just need to make the tumors more immunogenic. For whatever reason, sometimes the immune system just doesn't see certain tumors, and we could give these drugs, and for whatever reason, maybe the immune system is just not immunogenic enough. And there are a number of theories as to what makes a tumor immunogenic. One of the theories is that maybe the number of mutations that are present in the tumor is related to the immunogenicity of it. Other people think, in addition to this, it may be that the T cells, we saw those T cells killing those tumors, maybe they just need to be in the tumor to help fight the tumor. So different strategies of what can I do to make the tumor more immunogenic, or what can I do to bring more T cells into the tumor? Those are being explored. And the other strategies that are being explored in various combinations, and this is an area of many different clinical trials, is what strategies can we do to reduce other immunosuppressive elements within the tumor microenvironment, like myeloid-derived suppressor cells, which are believed to be negative immune cells, and as well as something called IDO, or 2,3-indolamine dioxygenase, which is another negative regulatory system within the tumor microenvironment. So getting rid of the bad within the tumor and maybe bringing more T cells into the tumor, or maybe inducing more mutations, these are some theories as to ways that we can build on our combinations. And so there have been many different combinations that have been studied in clinical trials, and there's been great interest in combining in melanoma drugs like BRAF inhibitors like vemurafenib or dabrafenib with MEK inhibitors like trametinib and some of these immune therapy strategies to see if we combine doublets and triplets of these to help patients more. These are still in clinical trials, and so it is important to consider that none of these combinations with targeted therapy are quite yet ready for routine clinical practice. Other immune therapy strategies have been combined together, and then other strategies involving standard anti-cancer treatments like radiation treatment have shown some benefits in mouse models, and we're exploring whether they're beneficial in patients. So I wanted to share two combination stories briefly as we work to the conclusion here. And one theory is radiation may be something that could help enhance the efficacy of these immune blocking antibodies or immune stimulatory antibodies. The idea for radiation is that if you irradiate a tumor, you may release more tumor antigens or bring more T cells into the tumor microenvironment. And then if you give one of these antibodies, either at the same time or thereafter, it may help patients do better than just the antibodies by themselves. Now, unfortunately, we haven't yet proven this in patients. So this is not something that I tell patients they should just get radiation just to help these drugs work better. But if a patient needs radiation anyways, I think it's reasonable to do radiation anyways in combination with one of these drugs. This was one patient that we took care of that had a very interesting response. And I think if a few people were here a number of years ago, I think this patient was shared at that time too. But this patient was on Ipilimumab. And if you see here this white arrow, there's a little tumor in the back that she had. And there was an area in the spleen to keep an eye on, and then a lymph node here around the lung. And what happened over time was this tumor in the back grew. And even though she was on Ipilimumab for a long time, this tumor continued to grow. And there were some new areas in the spleen that were developing. And because of some back pain that she was having on the left side near where on the right side where this tumor was, she received radiation treatment to this tumor, 28.5 gray and 3 fractions of radiation. And then over time, it looked like the tumor started changing, but it still grew a little bit. But over a longer period of time, the tumor not only got better, up here on the top panel, but also areas in the spleen where you could see in the middle panel in January of 2011 that were clearly involved with melanoma had improved. And unfortunately, or fortunately actually, this patient had a very long-term disease-free interval where she did very, very well after having radiation. And so this is an idea that this patient was not benefiting from Ipilimumab initially, had radiation, and then it seemed to change the trajectory of her particular course. Now again, unfortunately, this has not been proven in a clinical trial, so it's not something that we could say you need to have radiation with these drugs, but it's an interesting theory because in mouse models, it looks like this may be the case that these can be synergistic, and we need clinical trials to test for that. So patients have had these interesting effects where we see some benefit, but we really need clinical trials to know for sure. The other combination that's gotten a lot of attention really is if we have good results from drugs like Ipilimumab that block CTLA-4, and we have good results from drugs like Nivolumab and Pembrolizumab that block PD-1, what if you just put them together? They work differently, so maybe we should give both of these drugs to patients at the same time. And this was a phase 2 study that was done, and we're very grateful for patients that participated in this, where patients received the combination of both drugs, Nivolumab and Ipilimumab, or Ipilimumab alone. And I think the key is, in the patients that got the combination, the results were very, very impressive, and this led to the FDA's approval of this particular combination. The median change in tumors in this group of patients was a minus 70% reduction. So this waterfall plot shows that the majority of patients had shrinkage of their tumors with this combination, and that the average to be expected was a minus 70% reduction. So very, very powerful reduction in this orange group of patients here. Well, the patients weren't orange, but this is what was shown on the waterfall plot. And if you don't believe the waterfall plot, this was a patient that was treated with this particular combination. She was a 52-year-old woman that had a big melanoma lesion under her left breast. And you could see it's, it was painful. It was a real problem. And this was a patient that was taken care of by one of my colleagues, Dr. Paul Chapman. Here was a CAT scan showing the tumor. And what you could see, she got one dose of this combination of both of these drugs, blocking PD-1 and Ipilimumab. And 3 weeks later came back and said this tumor has just gone. And so this was really, really impressive. It was still a problem that there was a hole here. But hey, we'll take it. So this ended up getting, it took a long time for this hole to heal, and we were concerned about the hole. But it was amazing how well this treatment worked for this particular patient. Now again, this is just one patient's really remarkable response. Fortunately, she's not the only patient that's had this great response, but unfortunately, we wish it was 100% of patients that had tumors that were this responsive to immune therapy. And we don't still quite know why certain tumors are so responsive to immune therapies. Actually, there's a theory in lung cancer patients that took the PD-1 blocking antibody Pembrolizumab, that smokers actually had a little bit of a better likelihood of responding to these drugs because it induced a lot of mutations. it's absolutely not a reason to start smoking if you're taking this treatment, but just an interesting theory. And this is just a curve from the phase 2 study, from some information that these data were presented just a few weeks ago in New Orleans at the American Association for Cancer Research meeting, showing that what we see, this concept of a tail of the curve, is very, very important, and that from 1 to 2 years, it already looks like this tail of the curve has been established at really 1 year in patients that have received this combination. And so we want this tail to be 100%, of course, but it's a dramatic improvement with this combination over other treatments like Ipilimumab alone, as you can see here by the orange being higher than the green. When we put drugs in combination with each other, unfortunately, there are more side effects, and that's just what we would expect when we're combining multiple drugs with multiple different mechanisms of action. And sometimes patients that have side effects need to stop treatment to take care of these side effects with steroids or other treatments. And I think one of the key concepts is that it doesn't seem to matter how much of this that patients get. Even patients that stop different treatments can still have incredible benefits to this. And it's not a matter of how much drug is delivered. It's just a matter of how much is needed for that individual patient to turn on their immune system. So we want to know, is there a test that could pick people out who would best benefit from these drugs? We want to select patient. Patient A, you should get drug A, or patient B, you should get drug B. And unfortunately, there's not a perfect selection test to decide. There's been a lot of discussion about a drug target called PD-L1 as a potential biomarker or potential patient selection test in melanoma to decide if a patient is a candidate for these particular approaches. And I'll give a few thoughts on that and explain this a little, because this may be something that we hear about with our care teams. And this is a biopsy of patients that were looked for this molecule called PD-L1. And that PD-L1, again, that was expressed by these tumors that is a negative immune signal. And what we can see here is that there's a range of positivity. Some people don't have PD-L1 at all, 0. Some people have a lot of PD-L1, 80%. And so there's a spectrum here from 0 to 100% of PD-L1 positivity. And there's a lot of debate in the medical world now of what do you call positive or negative. So this is really a shades of gray issue, and we're trying to make it a black and white issue. And so sometimes there are problems about where you draw different cut points and how you decide if a patient is PD-L1 positive or PD-L1 negative, different ways of doing this study. So I don't think the final answers are yet available on the utility of this particular test. And that's due to a number of reasons. In addition to the fact that there are different tests that can measure PD-L1, sometimes patients in certain trials, it's really incredible benefits in patients that don't have PD-L1. So patients that are PD-L1 negative still have remarkable benefits to these particular treatments. And so it's not so simple that if you're PD-L1 positive, you should get one of these drugs, and if you're not PD-L1 positive, you should get something else. So we don't have a perfect selection marker just quite yet. And some patients will even have positive tumors and negative tumors in the same person, and so we're still trying to understand what that heterogeneity really means. So as we conclude, just a reminder, there are many different strategies to turn on the immune system. Vaccines, talked about cytokines with interleukin-2. We talked about adoptive cell transfer, where you give the T cells directly to the patients. And now we've talked about a new strategy called immune checkpoint blocking antibodies, blocking those breaks on the T cell to help them fight the tumor cells a little bit more strongly. And so what we've seen now is that long-term tail of the curve from interleukin-2 now has been dramatically increased with some of these other approaches, like CTLA-4 blockade with Ipilimumab and PD-1 blockade and the combination. We're still working on the perfect test to decide who will benefit the most from this approach. Combinations have promise, and we don't really know what the best combinations are. And so it's important that we continue to recruit to clinical trials for these particular situations and understand how do we best combine these drugs and how do we best sequence all of these particular drugs. And so in summary, I like to just end with a little cartoon picture. And again, I'm sorry this is not a video, but this is a way that we can think about our immune system wrestling with melanoma. So in the presence of melanoma, this is the melanoma, and this is the immune system. This little boy, really, really working hard to try to push over the sumo wrestler. But what we want to do with all of our immune therapy approaches is switch this equation so that this can be the immune system and this can be melanoma, and then we can squash the disease and we can do very well long term with all of this. So Thank you very much again. It's an honor to speak with you, and be happy to take any questions either now or if we move into the panel discussion. So thanks again for having me out here.